Welcome back to CGM Sweet Talk with the Sugar Queens. This is episode 7 of season 2. As you know, I'm Dr. Eden Miller, an osteopathic board certified family practitioner. I'm a diabetologist and obesity medicine specialist in Bend, Oregon. My queen, Jen.
Hi, I'm Jen Goldman. I am a clinical pharmacist. I'm a professor of pharmacy practice at Massachusetts College of Pharmacy in Boston, where I teach in the PA program and the pharmacy program, and I direct the cardiometabolic services at a practice called Well Life Medical in Peabody, Massachusetts.
Queen Bee Davida.
Hi, I'm Davida Kruger. I'm a certified nurse practitioner in Detroit, Michigan, and I'm thrilled to be here.
Today's title, we are tackling CGM and cardiometabolic health. For the next 25 minutes or so, we're going to discuss how continuous glucose monitoring can improve cardiometabolic health in patients with type 2 diabetes. Can you believe it? Another sweet Sugar Queens topic, looking about how to improve those comorbidities. We love to hear from you. We're so glad you're here live, but we want you to drop in those questions in the chat. You know, you can ask the queens anything. So this may be obvious to many listeners, but Jen, I want you to talk a little bit about why optimizing cardiometabolic health is so critical in persons with type 2 diabetes.
Yeah, absolutely. I always remind people that diabetes isn't just a sugar problem, it's a cardiometabolic disease. And so most of our patients don't get into trouble because their A1C is 7.4 instead of 6.8, right? They get into trouble because they have a heart attack or strokes, heart failure, kidney disease, or peripheral vascular disease. So when we're talking about optimizing cardiometabolic health, we're talking about protecting the heart, the kidneys, the brain, the blood vessels over the long term. So that means thinking beyond glucose alone and focusing on blood pressure and lipids and weight and inflammation and kidney function and glycemic variability. So the exciting part is we have newer therapies and tools like CGM. We can see those glucose patterns that drive cardiometabolic risk and intervene earlier. So before those events or amputations. And we'll walk through a real case soon where CGM helped us simplify therapy, get rid of insulin, shift a patient's cardiometabolic trajectory.
You know, I always say we have to treat the current person, which we know CGM does such a great job of treating the current person, but the future them as well. It's about bringing diabetes out of the past, right? CGM does that. It brings it out of the past into the present, and it can impact the future. Okay, Davida, you know, there is a lot of talk about glucose variability. It's actually one of my favorite metrics, but glucose variability can contribute to cardiovascular risk. You know, for those of us who don't know, glucose variability is what we call the high or low around the mean. So talk to us about how CGM can mitigate that risk, especially in those with type 2 diabetes.
Yeah. So first of all, I want to remind our audience that, CGM's been around more than 20 years. When it first came to market, it was just to prevent hypoglycemia. And look at what we've all learned about the benefits of CGM. And just think about all the episodes of what we shared and what it does to improve the life of people with diabetes. And it was designed for just type 1. And look at how we use it not only for type 1, type 2, and for people who don't have diabetes. But this is data from the Accord trial. Now, remember, the Accord trial is more than 20 years ago. I actually participated in this particular study, and it was trying to answer what we did in type 1 diabetes in the diabetes control and complications trial. But what was magnificent about this study is that it really pointed to the fact that glucose variability did in fact cause 19% and 23% higher risk of all-cause mortality associated with just one standard deviation increase in the A1C variability between intensive therapy and standard therapy. And then 61% increased risk of cardiovascular outcomes over 4.85 years in the highest quartile of the A1C. So the higher the A1C with the higher variability, 61% higher risk of cardiovascular disease, and then 34% higher risk of heart failure over 6.4 years. So of note, The higher A1C means a higher A1C variability, doubling the risk of mortality in the intensive therapy group, which was huge when you think about when this study was done, what we started out to do. And, we had a lipid group and a blood pressure group, and we really were paying attention to the cardiovascular. So think about what we were able to find that we didn't think. So the knowledge is high variability, high A1C, huge difference in the cardiovascular risk for people with type 2 diabetes.
There was also the Honolulu Heart Study. I remember back in the day too, the Honolulu Heart Study was an insulin study looking at the higher A1C, but it didn't have CGM at the time. They were looking at higher A1Cs and higher, blood peak to trough with blood sugars. I think that was there too. But it also as well. I think I love that last fragment there. Of note, that higher A1C, I tell people this all the time, and they're like, oh, I'm going to keep the A1C high to avoid hypoglycemia. It's like, you are not doing yourself a favor. It's your peak to trough, and that's what increases it. And also, low blood sugars can cause arrhythmias.
Yes. And I keep telling my patients that I'm very concerned about your hyperglycemia, but we also don't want you to have a lot of hypoglycemia. And that's where enter CGM, which we really didn't have that available to us before, but enter CGM, that we can now see the variability on a day-to-day basis. We can see what's happening with hyper and hypoglycemia, and we can move those patients down to time in range. Yeah. Which does decrease their risk of cardiovascular disease, heart failure, all that other stuff that goes with it.
I know our sweet Jean Wright always says that the time in range, that flat, lower variability, we're kind of, we didn't mention it. We're kind of looking for like under 25%, I think,
yes,
that thing. But it's the only flat line in medicine that you want, right? I always think it's funny. Jean Wright, our sweet Jean Wright, said that. Okay, Jen. Let's talk about other ways that CGM is helpful to improve cardiometabolic health. And for this, you have a very, very good case. So walk us through this case. Tell us kind of those details. Give our listeners a little bit of your experience of how you use CGM specifically with cardiometabolic health.
Sure. I'm going to introduce John. And this patient really illustrates his cardiometabolic story. So I actually knew John years ago, and he switched primary care to my office so that he could see me. He was previously managed elsewhere. So this is really his first visit. He was using CGM. So before I met him, he had CGM. So this CGM that you see is what he kind of came to me on. So he's 67, type 2 diabetes, significant vascular disease. He's already had a popliteal bypass on both legs, toe amputation, rotted endarterectomy, chronic kidney disease with an eGFR in the mid-40s, very atherogenic lipids. It paints kind of a scary picture. This is not what he looks like. He's sitting in front of you, but on top of this, when he comes in with these issues, he's on pre-mixed insulin. He's having nocturnal hypoglycemia that he treats with orange juice, and he's chasing his post-dinner highs. And just a note, no glucagon, never heard of it when I asked him. So this is the type of patient where just getting the A1C down isn't enough. We have to ask, how do we reduce his future risk of amputation and MI and stroke and heart failure? So there's where CGM becomes a cardiometabolic tool and not just a glucose gadget, right? It's a tool for cardiometabolic. So this is a cardiometabolic train wreck that I'm trying to slow down. So let's, look at the next slide. We'll look at his AGP a little further. So CGM's confirming what he's describing, right? Big post-dinner spikes, dips overnight. Time in range was only 60% on 76 units of insulin. He's on 38 units twice a day of pre-mixed insulin. And seeing this really gave me the confidence to be able to get him off the pre-mixed insulin and transition to something simpler, a safer regimen with basal insulin plus tirzepatide. In the past, years ago, he told me he was on semaglutide and he couldn't tolerate it. And there was a time that he was on dulaglutide, but due to shortages, he couldn't continue on it. So this is what he's coming to me on. Obviously, I would have a plan in the big picture because of his kidneys and other issues to be able to put him on an SGLT2 inhibitor. I intensified his statin, but at this point, this is kind of the first visit. What am I going to do? So he's on pre-mixed insulin. He's using orange juice for lows. He's chasing highs after dinner. High risk regimen from a cardiometabolic standpoint, right? So you just pointed out hypoglycemia, arrhythmias, QT changes, inflammatory surges, wide glucose swings he has. So endothelial dysfunction, oxidative stress, weight gain from insulin. So from the very beginning, I used CGM to do two things, right? Reduce the acute risk, less hypoglycemia, less variability, and to really set him up on therapies that actually improve cardiometabolic outcomes. So when we look at the next slide, what you can see is by doing that, I changed him from 76 units of premixed insulin to 20 units of basal insulin and 2.5 of tirzepatide. And what happened? His time in range went from 60% to 87%. And I just wanted the audience to see what, beside the AGP, when you can see those glucose logs, and what he's doing is he's writing notes to himself on what he ate, what he gave himself, so that he could see, when I eat this, this is what happens. And he's doing this on a daily basis. So when I saw this, I felt pretty confident. So I decreased his basal insulin to 10 units. So we can see what happened on the next slide, 2 more weeks later. So on 10 units, he's in 99% in range now.
Wow.
It's crazy, but hey, you can see how he's paying attention to what he's eating and what he's doing.
He's engaged. He's totally engaged.
He owns his own diabetes now. Yeah.
Totally engaged. So I stopped the basal insulin for sure. So we went from 76 units of premixed insulin to 0. And if we go to the next slide, what happened? So this is a couple weeks ago. So stopping that premix was not just about convenience, right? It's about cardiometabolic medicine. Yeah. So less hypoglycemia, fewer arrhythmias, less cardiovascular stress, less glycemic variability, improved endothelial function, weight loss, weight reduction. So we reduce heart failure risk, reduce inflammation. So take a look at his notes that he's writing. And one of the things he writes that, I kind of chuckled at is, won't have Dave's toast again, big spike in blood sugar. I mean,
I love Dave's killer bread. I love that bread.
Exactly. So CGM made this possible by showing us both risk and kind of opportunity. So just looking at his CGM after the therapy adjustment, if you look over to the right, we have smoother curves, reduced spikes, fewer dips. So this improved glycemic stability. And by doing
that's good.
This itself has cardiometabolic implications, right? What you were just talking about earlier, lower variability associated with lower rates of retinopathy, less oxidative stress, fewer cardiovascular events. So next steps for him is, we will be addressing his CKD and further cardiovascular risk with medications. And he's thrilled. He says he feels better than he has in many years. So, for him, changed everything. Well, we look at his regimen, big swings, post-meal hyperglycemia was, followed with those overnight lows. This pattern that he had is really miserable for patients, right? So associated with higher cardiovascular risk. So certainly doing better. So with CGM, we could de-intensify insulin. We were introduced to a drug, optimized metformin, time in range is improved, feels so much better.
The Queens could have used John's case for multiple episodes.
Yeah.
It could have used for engagement, for insulin titration. I mean, I took
adherence. Yeah.
Yeah. I took two things. When you started out with the insulin go gadget or the glucose go gadget. But I loved your term glucose stability.
Mhm.
That was good. I don't know that I've ever heard it put that way. Wow. What a life changer.
Yeah.
I mean,
So his glucose variability was under 20%. All those little puffy cloud things from the beginning, they were gone. Just a nice flatter line. And here's the thing: when you see that much insulin in the beginning and that little insulin is 0.25, a 2.5 tirzepatide doesn't cut that much insulin down that you can stop it. Usually, you have to wonder if the dosing was right, the type of insulin was right, and if the insulin actually got under the skin before he could see the data, make notes to himself, and see what Dave's bread did. And I don't care if the answer was that he wasn't taking all the insulin before, and CGM allowed him to see so much that now he was taking what we prescribed. That's the beauty of CGM. And guess what? The outcome is a better cardiovascular outcome, less risk of cardiovascular disease. Great case.
You mentioned early on, Davida, about, and I still think there's some of our listeners and some of our people out there thinking that CGM is only for hypoglycemic protection.
Nope.
It's not. That's a minimum. Like if you're on any kind of insulin or sulfonylurea, or I don't care if you're type 1, type 2, you're not on CGM, you are not following the minimum, right? But you, with this case, which I think is one of the best comprehensive cases we've had, you essentially overcome every barrier of his diabetes management utilizing CGM as a facilitator. Even like you said, somebody say, oh yeah, because he wasn't taking his insulin. I don't care. It doesn't matter.
Now he's doing it. Yeah.
Now he's doing it. Or now he knows what food is, and now he's engaged, and now you've reawakened his cute little diabetes journey. It's like, it does not matter.
He was actually taking his insulin, so I could look back, and he was noting it in that. So he was taking it. I think that, we have to think about some pharmacogenomic type things and super responders and things like that.
70-30 is the best choice either.
For sure. I think in this case, this is what it looks like when CGM is used as a cardiometabolic intervention and not just a glucose monitor.
Yes. Yeah. Well, but I also think that it behooves the listeners and the clinicians to come to terms with the fact that CGM offers benefits way beyond anything we ever thought it was going to do for our people with diabetes. And here we go. CGM's a right, not a privilege, that every patient with diabetes should be afforded. And look what happened to this particular individual. You decreased his cardiovascular risk because of all the things you did, because you stepped up and said, give him a sensor.
Yeah, I love it. And, we could talk the rest of the time about John. He's quite compelling, but take us through a little bit about how CGM, we know it improves glycemic control. There's so many trials related to that. So let's pull up that slide and let's look at that improved control.
Okay. So, next slide. Yeah. So here's the first slide that there's a bunch of research, and I can't even begin to touch, which again brings me back to my very, very, very first comment about who knew that when CGM came to market 20 years ago, I would be sitting here talking to you about the cardiovascular benefit. The three of us are sitting here. So this is a study done by Earl Hirsch and Company. And he looks at the change in A1C over time by sensor use. Again, something very important is that, first of all, once we put a sensor on him, I don't know about you guys, because I think even 5 years ago, people were like, yeah, sensor set. Now, if a patient's sensor hasn't arrived in the mail and they might have to go 12 hours or 24 hours without a sensor, they're hyperventilating because they don't want to be without their sensor, right?
Yeah.
But this study showed you individuals who had it 1 to 90 days, 90 to 180 days, 180 to 270, and greater than 270. And the longer the patient stays with the sensor, the better the outcome.
Durability.
Yeah,
exactly. And so it's a very simple outcome. but very important to understand that we really want people to have sensors, wear them, and use them. And it may be they're using the data in different ways than I as a clinician, but it gets them through every day, like John, who doesn't want Dave's bread. So the next study, again, here's this data. So CGM is associated with reduced ASCVD risk and improved outcomes in patients with type 2, not on insulin. I'm going to say that again, not on insulin. And this is a 90-day study with 47 individuals with type 2 diabetes and high risk of cardiovascular disease. And by using a sensor, the 10-year predicted risk went down by 24%, and then CGA associated with reduction in the absolute 10-year predicted risk for ASCVD by 8%. And this is Dr. Reed's study. And then,
is this a tool or a therapeutic intervention?
Seriously.
Exactly. And you can see what happened with triglycerides, blood pressure, total cholesterol. Now, I'm not going to show the data today on another study, but there is another study that shows that by giving a patient a CGM, the healthcare provider was finally looking at the data. And because they were looking at the data, they said, oh, maybe I should be using CGM, GLP-1s that have a cardiovascular benefit and SGLT2 inhibitor. And because the primary care providers were finally looking at the data and giving sensors, the patients had a better cardiovascular outcome. Again, I don't care how they get there. I was just thrilled with that research as well. And then this shows you some other research that was done by Dr. Nathanson, looking at retrospective compared cohort study that included adults with type 2 diabetes, started CGM after 2007. Patients were treated with multiple daily injections on basal insulin with or without glucose-lowering drugs, and significant reduction in A1C in people using CGM versus capillary blood glucose and treated with MDI, and they had fewer hospital admissions for cardiovascular events compared with blood glucose individuals. And there's a huge list of people who thinks that they did not have cardiovascular events that they were hospitalized on. Their time in range was better. Their A1C was better.
Oh, I love it.
And then this slide, I think this is a great slide. It's a VA slide that Dr. Raven did. We all use it for a lot of things when we're talking about CGM. And it looked at CGM initiation versus SMBG in type 1 and type 2. In the type 1 cohorts, a huge decrease in CGM hypoglycemia admissions. In the type 2, decrease in hyperglycemic emissions, and all hospitalizations for all of these individuals were decreased by utilization. So if we get rid of the hypoglycemia, and we know that causes cardiovascular risk in type 1s, and in type 2 diabetes, we get rid of the hyperglycemia that causes hospitalizations, we decrease those individuals' cardiovascular risk as well.
And this is money.
Yeah.
And what I mean by that is, and you know, the queens don't always talk money, but this is for those listeners out there, you know, looking at cost economics, looking at benefits. You know, this is that every hospital-based system or accountable care organization or quality improvement should be looking at this, because this is preventative acute related events, you know. And you know, wouldn't it be great, like, if we all got stung by a bee, the queens got stung by a bee, and we had to go in and we had this reaction, we would leave the emergency room in the hospital with what? An EpiPen.
Yes.
You know, wouldn't it be great if it was standard of care that when you went into the hospital for an acute related event, high glucose, low glucose, you know, that kind of thing,
yes,
and you had type 1 or type 2 diabetes, you would leave with a CGM, because that would be directly to prevent, you know, that kind of thing. Okay, so we're getting close. Jen, just kind of wrap up that cardiovascular. We saw that data from Davida. It's like independent cardiovascular data. We know about hypoglycemia, but why is it imperative that, especially a person with type 2 diabetes, not get hypoglycemic?
Yeah, that's such a good point. I'm glad we're talking about it. Hypoglycemia is scary in that moment, but it has cardiometabolic consequences. So we know that severe hypoglycemic events are associated with arrhythmias, QT prolongation, sympathetic surges, endothelial dysfunction, inflammation, So they're linked to higher rates of cardiovascular events and all-cause mortality. So patients with current severe hypoglycemia have higher rates of cardiovascular events and accelerated atherosclerosis over time. So when
Yeah.
CGM helps us reduce both the frequency and severity of hypoglycemia, especially those unrecognized overnight events, that is cardiometabolic prevention. So, not just a diabetes gadget again, it's cardiometabolic prevention. So
And
we're protecting the heart, right, from repeated hits of hypoglycemia. And at the same time, we're giving patients, clinicians that confidence to optimize therapies that improve long-term outcomes. And this is true for both type 1 and type 2 in that large VA study that Davida
yeah,
just
Right.
CGM was associated with hospitalization, hypoglycemia, and lower all-cause hospitalization. And that's exactly what we want to see when we're thinking about cardiometabolic health across the spectrum of diabetes.
and
Well,
people with type 1 are no different either.
no,
We
no, no.
Type 1 and 2.
And we didn't include this research, but Eden's published on this, and Tom Grace has published on this. If you give someone who is not on insulin, their A1Cs are high, we're talking 9 and 10%, and you give them a sensor and you don't make adjustments, what the patient learns from the daily use of a sensor can decrease that A1C and glucose variability. Decrease A1C, we've seen up to 2% in the paper that Eden presented. And so I think, again, we're talking about a tool that I don't have to be super engaged if as a clinician, I'm not comfortable with it, but your patient will be super engaged. And at the end of the day, they will get decreased glucose variability, better time in range, ultimately a better A1C if that's where you hang your hat as a clinician, and the outcome for that patient will be so much better.
When you said that, my first thought that hit in my head was multi-tool. Those multi-tools, CGM's a multi-tool.
Yes.
Let's not put it in a box.
Right.
Let's not put it in a hypoglycemic box. Now, we're going to say it. If you have hypoglycemia from any cause, from any kind of therapy, in any type of diabetes, you must have a CGM on there. However, that is safety. That's not the whole CGM story.
Right.
The whole CGM story that us as queens are trying to get across is that there are so many layers of the CGM story.
Mm-hmm.
I think of it like this, that CGM has given us a clearer view of diabetes. It's taken diabetes out of the research and into the individual. CGM is an individual journey of diabetes. It is customizable. It is their map and their GPS that you as clinicians, I don't care what part of the team you're on, you could be every part of the team, get used to seeing CGM data. Ask yourself whether you're a dietitian or a PharmD or a CDCES, or even we welcome cardiology, as we were talking about cardiometabolic health, to engage in the data, get used to seeing the data, to look at it and say, how can CGM in my world, in what I'm trying to accomplish with the patient, how can that give me insight into this individual to make meaningful impact? Because the CGM speaks all the different specialties, speaks all the different ones. Well, what an amazing episode. I think we did really good today, Queens. I loved the case. Make sure you're getting credit. We want you to get credit, even though we know that you love us just because you love to see us Queens, but get credit. Mark your calendars for our next upcoming Queens. If you want to go back and look at some of the archive Queens, you can find that. Don't forget to bookmark us here on YouTube. All of our recordings are posted, and you go back, you can look, because you know that you just can't get enough of us Sugar Queens. And I'm looking forward to our next time when we meet with you. We're going to go through some really fun stuff. So please mark it on your calendar. Look forward to seeing all of you, and please have a happy, healthy, and blessed holiday season. Thank you so much.
Bye.